This podcast is brought to you by Intranaturals, an honest, natural, and high-quality brand of supplements available only online. People's Pharmacy listeners get 25% off their first order using the code PEOPLES25 at intranaturals.com. That's code PEOPLES25 for 25% off at intranaturals.com. Is the old paradigm for cancer treatment about to change? How can the immune system be mobilized to fight cancer? This is the People's Pharmacy with Terry and Joe Graydon.
For decades, cancer doctors have relied on surgery, chemotherapy, and radiation to counter this dreaded disease. But 100 years ago, one cancer surgeon found a unique way to stimulate the immune system to attack tumors. Researchers are now going back to the future with modern immunotherapy.
We'll talk with leading cancer researchers about the latest developments in the rebirth of immunotherapy. We'll find out how oncologists are recruiting T cells for cancer treatment.
Coming up on the People's Pharmacy, the latest developments in the war on cancer.
First, the news.
In the People's Pharmacy Health Headlines, long-lasting lower back pain responds surprisingly well to both mindfulness-based stress reduction and cognitive behavioral therapy. These mind-body approaches are not usually considered mainstream treatments for chronic back pain, but a new study in JAMA suggests that they deserve far greater respect than they usually get. In this trial, 342 adults with chronic back pain were randomly assigned to get usual care, classes in mindfulness and meditation, or cognitive behavioral therapy. Both the stress reduction approach and the behavioral therapy produced significant improvement. Roughly 44% in both groups found that they were functioning better and their back pain was less bothersome at the end of 6 months. That compared to 26% of the people getting standard care. Given the recent CDC guideline recommending against narcotic medications for chronic pain, it would seem that mind-body interventions are well worth consideration.
The FDA has followed the lead of the CDC in cautioning doctors in prescribing opioid pain relievers. Short-acting narcotics will now come with a boxed warning about misuse, abuse, addiction, overdose, and death. Longer-acting narcotics already come with boxed warnings. In addition, the FDA will require that all narcotics carry a warning about drug interactions with certain other medications that could trigger something called serotonin syndrome. This condition can cause agitation, confusion, rapid heartbeat, elevated blood pressure, uncontrollable muscle contractions, and elevated body temperature. Nausea, vomiting, incoordination, and even hallucinations can also occur with serotonin syndrome, and severe cases can lead to unconsciousness and sometimes death.
People in pain, especially those with arthritis, have relatively few good options for relief. Non-steroidal anti-inflammatory drugs such as diclofenac, ibuprofen, or naproxen can cause gastrointestinal injury that may result in ulcers. In addition, such drugs raise blood pressure and may increase the risk of cardiovascular complications such as heart attacks. If arthritis patients complain of stomach upset, they're frequently advised to use acetaminophen, the active ingredient in Tylenol. A new study evaluating results from 74 trials found that they could not justify a role for acetaminophen in treating osteoarthritis pain at any dose. High-dose diclofenac emerged as the most likely to alleviate osteoarthritis pain, but side effects may limit its usefulness.
Stress management techniques can dramatically lower the chance of a repeat heart attack. Researchers at Duke Health randomly assigned 151 people who had suffered heart attacks, bypass surgery, or other cardiac events to either a traditional cardiac rehab program or to the same program plus 90 minutes a week of stress management. The cardiac rehab included a heart-healthy diet, sensible exercise, and medications for cholesterol and blood pressure control. After 3 years, a third of those in the cardiac rehab group had experienced a subsequent cardiovascular event. In contrast, only 18% of those who had participated in the stress management groups had such a complication. Both of these groups did much better than patients who opted out of cardiac rehab. Nearly half of them suffered complications or died during the follow-up period. Lead investigator Dr. James Blumenthal suggests that stress management should be included in cardiac rehab programs, although that's not currently standard practice.
Bisphenol A, BPA, used to be a common ingredient in water bottles and plastic food containers. When scientists showed that BPA had hormone-disrupting activity, consumers started looking for alternatives. Soon, BPA-free plastic bottles proliferated. But the replacement for BPA is frequently bisphenol S, BPS. Now, a study published in the journal Endocrinology suggests that both BPS and BPA make fat cells proliferate. In this test tube research, cells were exposed to varying concentrations of BPS. Even very low levels of the chemical triggered lipid accumulation. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. Cancer remains one of our most daunting diseases. It may soon overtake heart disease as the #1 killer of Americans. Despite billions and billions of dollars spent on the war on cancer, progress has been slow until recently.
For decades, cancer treatment relied primarily on surgery, chemotherapy, and radiation. The idea was to remove tumors or kill rapidly growing cells. But even when you remove or kill 99.9% of a cancerous growth, you leave behind thousands or even millions of cancer cells. They can gradually regroup and return to cause recurrent malignancies. But we're now at the dawn of a new age in cancer treatment called immunotherapy.
To learn more about this new approach to cancer treatment, we turn to Dr. Sharon Evans. She's professor of oncology in the Department of Immunology at Roswell Park Cancer Institute.
Welcome to the People's Pharmacy, Dr. Sharon Evans.
It's a pleasure to talk to you again, Joe and Terry.
Oh, it's so nice to have you, Dr. Evans. And, first I have to say that probably the hottest area in cancer research and treatment these days is immunotherapy.
Well, I'm wondering what is responsible for the transition that seems so recent of cancer immunotherapy from a really esoteric scientific discipline that hardly anybody knew about and that really wasn't being used to treat cancer to its current status as a potential frontline treatment and breakthrough.
So you raise such an important point. This is a very exciting time for all of us as scientists and clinical researchers to be involved in cancer immunotherapy. But I think the key is why it has all this promise and excitement is that it's built on literally decades, even hundreds of years of research that have all come together at the right time and the right place to push this forward. So in my mind, what has made this now, we're enjoying a renaissance. And the word renaissance in French means rebirth. And I think it's very apt for this topic because we're really exploring and re-exploring the power of the immune response and how it can fight cancer. So one of the seminal things that has happened is we now recognize from the landmark studies of Laurent Zievogel and Guido Kromer in France that there is an impact of the immune response on frontline therapy. So things that were always thought to directly kill rapidly dividing cancer cells, like radiation or chemotherapy, are now understood to absolutely depend on the immune response. And so now, instead of being maybe 7th or 8th line consideration for therapy, we realize that the immune response is critical for all types of therapy. And that's really changed the complexion of how we think about it.
So if I understand what you're saying correctly, before the research was done that you just talked about in France, we thought radiation works just because it kills cells. And now what you're saying is radiation works because when it kills cells, it alerts the immune system, which then goes into action.
Yes, exactly. It's in fact a very potent way of re-educating and diverting the immune response to give it a kickstart.
Dr. Evans, you talked about how the current renaissance in immunotherapy was built on research going back over 100 years. And this sort of reminds me of Dr. William Coley's work, in which he didn't understand very much about the immune system, but around the turn of the century, and we're talking about 1910, 1915, he was injecting directly into sarcoma cells, a very hard-to-treat cancer even to this day, with a gamish of bacteria and then ultimately a toxin from those bacteria. And he was doing it on a regular basis, like weekly, and he was stimulating a high fever, and he was measuring the success of his treatment by how high the temperature rose. And he didn't know that he was stimulating the immune system, but he knew that the cancer was basically going away as a result of his treatment. Is that some of the research that also is now has built upon to create what we now have today?
Yes, I think the groundbreaking studies of William Coley, and as you say, the problem was that it wasn't an absolute. So while there were some patients where the tumors literally melted away, there were many other patients that succumbed to their cancer or were adversely affected by that very profound inflammation. It's almost like the Goldilocks thinking. Too little inflammation isn't good and too much isn't good. So you're finding that right balance. So many of the current immunotherapies do virtually the same thing. They ramp up the immune response. They're often associated with high fever. And that is almost a bellwether of whether you have an immune response working. And you need that to happen, but you can't have it too uncontrolled. So that's kind of the finesse of the immune response, is that it can be very tightly regulated, but being careful about that is key. In fact, our own research really focuses on some of the immune-promoting activities of fever. And so it's not all that far afield from what William Coley started, as you say, over 100 years ago.
Now, you've mentioned something I think most patients are not aware of, and maybe even some oncologists as well, and that is that the immune response has to be in what we call the sweet spot. You can't have too much, because then the body begins rejecting itself, a kind of autoimmune reaction, and that's not good. But too little immune response means that the cancer then can take over. And you talk a little bit in your research about how these, what do you call them, the CD8 cells need to infiltrate the tissue of the tumor itself, and that is the best prognostic indicator of how well the immune system is going to be able to fight off this cancer.
So in thinking about these, as we term them, CD8 T cells, but one way to think of them they're the professional killer cells in the immune response. They're the cytotoxic killer cells. And the way they work, the key is that there are multiple parts of the immune system. There's the phase where you need to have a sufficient number to exceed the threshold, in a sense, of how many cells are necessary to kill. So that's an important key aspect of the immune response. And I think with all the advent of cancer immunotherapy, we've really gotten very good at increasing the frequency of immune killer cells. But a second phase is those cells have to get out of the blood system, out of the other lymphoid organs, and into the tumor site. And that's a very key. We also consider that a checkpoint in terms of tumor control, because in the end of the day, these cytotoxic killer T cells only work if they're in intimate contact with their target. And in fact, that's really the beauty and the elegance of the immune response. So they deliver lethal hits with surgical precision. And so as a result, they can kill cancer cells, and right next door can be normal cells. Because when you think about it, in cancer, that's what differentiates what we're trying to do in cancer immunotherapy versus other typical vaccines where we're fighting infection, is we're really targeting cells that are virtually your same cell type. If you have liver cancer, these are liver cells that have gone slightly bad, but they're right next door to functional tissue that you have to maintain your entire integrity of your body. So that's how these killer cells work, and you have to have a sufficient number. And then the third concept is just having them there isn't enough, because what they face when they get there, the cancer is incredibly agile, and it sets up a barrier. And it's sort of like the Star Wars. We're thinking about the anniversary of the Star Wars. It's that force field that gets set up by the cancer cell, and it literally blunts the immune response. So there are multiple challenges being faced when you're thinking about an active cancer immunotherapy.
Well, I think we'd really like to go through all three of these steps, but I'm totally fascinated by the idea that these killer cells can discriminate between healthy liver cells, as it were, and cancerous liver cells. Do we have any idea how they do that?
So they're equipped on their cell surface with these molecules, for example, T-cell receptors, that can discriminate these minor differences in molecules on the surface of the cancer cell. So one of the things that typically accompanies cancer development are these aberrations or mutations in proteins. So they'll be subtly different, and they get put out on the surface. And so the immune response can detect that and say literally that this cell is slightly off. And often it's a function of its very proliferative capacity, some of its very aggressive properties that allow this cancer cell not only to grow at high rate in the tumor at, say, the liver, but then move and metastasize, disseminate to other organs, say the lung or other tissues. So the immune cell can keep pace and recognize it, and actually can follow it to multiple sites as well. That's one of the other powerful aspects of the immune response. And the third one that is worth mentioning, because it really differentiates it from conventional standard therapies like surgery or chemotherapy or radiation, is the immune system can remember if it's seen cancer. So if you eliminate the tumor and it comes back, the immune response is in a great position to do that. Just like when we're vaccinated, we can recall that vaccination and protect long-term. It's a durable response.
You're listening to Dr. Sharon Evans, Professor of Oncology in the Department of Immunology at Roswell Park Cancer Institute. She's the former president of the National Society for Thermal Medicine. Her research focuses on the cues that drive immune responses during inflammation or cancer immunotherapy.
And Terry, durable remission, I think, is the new approach. You know, we like to think of curing cancer, but if we can keep cancer at bay for years or maybe even decades, that would be the wave of the future.
And that's how immunotherapy with its durable response comes into the picture.
After the break, we'll talk about some extraordinary, though expensive, new drugs for cancer.
Are there ways to mobilize the body's own immune response?
We'll talk more about how we can use heat to kill cancer and how the immune system reacts to that.
What is the role of fever?
We'll find out about the challenges facing cancer immunotherapy.
And we'll find out what Dr. Evans sees for the future.
We'll also explore the difference between finding a cure for cancer and finding a way to live with it.
You're listening to The People's Pharmacy with Joe and Terry Graydon. Thanks for listening to this podcast of The People's Pharmacy. If you like it, why not rate or review it in the iTunes store? We'd appreciate it.
Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon.
The People's Pharmacy is brought to you in part by Redix Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. The number is 800-345-7339. The website is uttercream.com.
If you'd like to purchase a CD of this show, you can call 800-732-2334. This is show number 1029. That number again, 800-732-2334, or you can place the order online at peoplespharmacy.com.
Today on the People's Pharmacy, the topic is immunotherapy. How is it transforming the treatment of cancer?
We're talking with Dr. Sharon Evans, professor of oncology in the Department of Immunology at Roswell Park Cancer Institute. She is the former president of the National Society for Thermal Medicine. Her research focuses on the cues that drive immune responses during inflammation or cancer immunotherapy.
Dr. Evans, there are some really extraordinary new drugs in the treatment of cancer. Of course, one of the first was Gleevec, which has revolutionized certain kinds of leukemia. But we also have drugs for melanoma, for example. But these drugs are pricey. I mean, they can cost $100,000 a year, in some cases even over $150,000 a year. They may extend life for some cancer patients a couple of months, but they often have pretty severe side effects, triggering immune system reactivity. So I'm just wondering, are there ways to mobilize the body's own immune system without a drug that's going to cost $150,000 or maybe soon $200,000 a year and produce tremendously difficult side effects?
I think that's truly, you've hit on what is one of the major challenges as we go forward with empowered basically with this information about what parts of the immune response we want to activate. But at the same time, how to balance that so it's cost effective. And as you mentioned, because many of these drugs that are coming forward, for example, some of the checkpoint inhibitors that were the front line, that targeted immune suppressive molecules like CTLA-4, for example, that's a molecule that can literally blunt the immune response. They're very expensive, and they can have relatively modest effects, maybe extend overall survival by 4 months. Some of the cell-based immunotherapies are even more expensive because you're using a patient's own immune cells to try to target cancer. So those are some of the challenges, and one of the ways that people are thinking about it is try to, in a sense, do a vaccination, but right in the body, so that some of the therapies that ablate tumors, for example, using very, very, very high heat, up in the level of boiling or 100 degrees centigrade, or very cold temperatures can kill the tumor, but they leave the tumor right in the body, and that is a little depot of immune signals that can activate the immune response. So there's a lot of thought towards doing that, but generally you need more to really boost the immune response. These immune responses, because you're going in, you're treating patients that already have the suppressive network set up. So generally, I think the key will be combination therapy, where you have more effective responses using less treatments and so on. Some of these treatments are very powerful with just one-time treatment.
Well, I'm kind of curious to go back to this idea of hyperthermia or elevated temperature, which you have talked with us about in the past. And just raising the temperature, 103 to 104 degrees, seems to have an immune stimulating effect. Has anybody actually looked at ways of raising the body temperature to attack cancer?
So in our research, we have kind of two sides of our research program. Part of it deals with the natural physiologic response of fever and how it can modulate the immune response. And the other half is dealing with ways to boost the immune response to cancer. And so it's obvious that they would overlap. Generally, in most of our experimental work that's been published, when you simply elevate the temperature to the febrile range in preclinical models, you can boost the immune response, but it's not enough. The host's own immune system is already in a state of blockade in a sense. So generally where we found that these therapies are effective, if you're talking about really the febrile range, it doesn't really diminish or shrink the size of the tumor on its own. It's really only effective when it's combined with other immune-boosting therapies. One example would be the approach that Steve Rosenberg at the National Cancer Institute here in the United States has taken, where you can adoptively transfer very, very large numbers of these killer cells. And then that army can be mobilized if you use these various preconditioning strategies that will, say, for example, febrile temperatures that can improve the rate of trafficking. So I think, again, most of us are thinking that just one strategy, because the immune response is so flexible and so susceptible to both positive and negative regulation, that just one approach alone won't be enough. But it can be very powerful when used as an adjuvant, in a sense.
Before we move on to other research that you're involved with, I'd like to ask you a little bit about spontaneous remissions, because this is something that's very hard to study. It's unpredictable. It's rare. And a lot of cancer doctors actually get a little nervous when you bring up the topic, because it's like, well, maybe it wasn't really diagnosed correctly. Maybe it wasn't really cancer. We don't know what to do about it. We certainly don't know how to study it, and we don't know how to use this information. And yet a lot of those spontaneous remissions have to do with some bad infection. You know, somebody came down with something and it led to this really high fever, and then all of a sudden, weeks or months later, that cancer that was supposed to kill them, it's not there. Can you tell us a little bit about those spontaneous remissions and if you've looked into that at all?
So many of those cases, as you mentioned, those are incredibly difficult to study experimentally, because it's hard to sample that microenvironment and take a look to see what's going on actively. So things are put forward more at a theoretical level, as far as often patients where you see remissions have a history of a high level of infiltrating immune cells in their tumors and so on. But it's incredibly, I can't understate the challenges of cancer because it's so heterogeneous. Two individuals with the exact same type of cancer, that cancer will be different. You're talking about truly personalized medicine in that sense. And a primary tumor will be very different than its behavior at a metastatic site. And two metastatic nodules in the same patient will be very, very different in terms of immune infiltrates, in terms of biological properties of that tumor, et cetera. So it's been very difficult, although many people are interested in spontaneous remission, to get hints about what we need to achieve. But it's been challenging to really dissect that.
Well, maybe you can tell us a little bit about the challenges facing cancer immunotherapy when it's used to treat cancer.
I really think so. One of the challenges is what we've just been speaking about, is this concept of spatial. That means where in the tumor you're looking can be very different. So what we think of it as almost like microdomains. Around the edge of the tumor is almost an entirely different disease than at the center of the tumor. So those are some of the challenges, and where the tumor is located, if you're talking about a primary site and a metastatic site, and so on. So one of the challenges is figuring out which patients are likely to respond to a particular immunotherapy, and what are good biomarkers, and then how accessible. Is it enough to go in, take a core biopsy from a single site in a tumor? Do you have to look at multiple metastatic sites, which is very, very difficult to do? And really why you're considering the immune response as a part of your arsenal of fighting cancer is that you want it to be able to go out to sites where you don't even know there's tumor lodged. So those are some of the challenges that we're being faced, is identifying what makes a patient responsive. Now, there have been some nice advances in a major therapy that I think has changed also how we view immunotherapy, are the successes that have been coming out of various groups, particularly the group at Johns Hopkins, at MD Anderson, Sloan Kettering, the Dana-Farber, and many other places that are focusing on immune checkpoints. And so it's becoming more apparent that if there's evidence that these molecules One of the one is called program death 1, PD1, and its ligand, PDL1. If there's evidence that these molecules are present at tumor sites, that may be an indication that patient would be responsive. But it's been very, very difficult to really land on what will dictate whether patients are responsive or not. So that's one of the big challenges that we're really facing. And then the other is that there are various tumor types that have turned out to be quite resistant. So melanoma is an example of a very responsive tumor. In fact, many of the landmark studies that have been done around the world have focused on melanoma because you can attack it with the immune response. Renal cell carcinoma, various types of lung cancer are turning out to be more responsive to immunotherapy. But there is still a large list of cancers, breast cancer, colorectal cancer, prostate cancer, ovarian cancer, pancreatic cancer, that are very, very difficult to treat with immunotherapy. And I think that's the challenge that we're facing, is what's the mechanism of resistance?
Dr. Evans, when you say immune checkpoint, can you explain what that means?
It's a very elegant system where the immune response, even when you're fighting microbes like bacteria or virus, the key is you want to ramp it up quickly within a few days, fight the infection, and then bring it back down, because you don't want your entire immune response dedicated to that single microbe. You need to have massive protection to anything else that you're attacked by, right? So it's the same in cancer, except in the case of cancer, we want it to stay ramped up and constantly be in a state of surveillance. But cancer is going to act like any normal immune response. Once it gets ramped up, then cancer cells start expressing various molecules, like the example we just talked about, PD1 or PDL1, which then, when the killer T cells come in, they have counter receptors. Once those get engaged, the T cell no longer can expand, and you need a large army constantly being replenished in order to control tumors. So these immune checkpoints, there are others. The studies of Jim Allison first identified CTLA-4 as part of the immune checkpoint that blunts and turns down. It literally dials down the immune response. So, and there are many others that have been identified as well. So what we're getting a picture now is in a cancer that has developed in patients over many years, 10 years, 20 years in many cases and more. That is a system that's really primed for setting up these negative checkpoint blockade systems that are in place.
Dr. Evans, for decades, the way oncologists approached cancer was kill cancer cells. We call that cytotoxic approaches. So that was how they thought chemotherapy worked. You have to kill the cancer cells faster than you kill the normal cells, and hopefully you win the race. That would be called the seed approach, because they look on cancer as seeds, as bad cells. And then along came the idea of soil. That is to say, the terrain, as David Servin Schreiber talked about, the microenvironment in which the seeds, the cancer cells, were growing. It sounds like the immunotherapy approach that you're talking about is more of the soil approach. That is to say, the body's receptivity to those quote-unquote bad cells. How do we unite these two approaches, the idea of these bad cells that are mutating and doing all of these terrible things? How do we, try and get rid of them at the same time nurture the soil to be resistant?
So the soil is complex. And I think that's one of the things that's really changed in how we think about cancer. We used to think of it as predominantly the malignant cell, growing out of control, dysregulated. Now we realize that a considerable part of the tumor mass, it can be 50% of the tumor mass, are immune cells. And they're not all the same type of immune cells. So you can see how complex it is. So I think that's really the balance, because each one of these cell types can be converted to being tumor controlling or helping the tumor. And that's that balance that's incredibly difficult to achieve. So incredibly complex. I think you're right. We're trying to support the anti-tumor side of the immune response, but not always easy to achieve.
Dr. Evans, what do you see for the future? Where is your crystal ball leading us?
To me, this is the most exciting time to be in cancer immunotherapy, because we now understand at a molecular level the players. And while it's still the tip of the iceberg in terms of success, many of the highly touted clinical trials that have come out that have shown successes still have their early phase studies. They're the first wave in a sense. And so we have a long way to go. But I think where the future is going to be is that we're going to be getting better and better and better at harnessing the various modalities so that they work together, using immunotherapy in combination with chemotherapy or radiation and surgery and hormonal therapy, etc., genomic profiling, exploiting the fact that if you have more mutations, that may be a better environment for the immune response to attack. So I think that that's going to be the real future in terms of where we go and where the successes are likely to come out. I think also thinking about cancer as a disease that we don't necessarily, we throw around the term fairly glibly of cure. The idea that you eliminate every last tumor cell in the body is often what we're trying to achieve. But I think the more realistic view may turn out to be that by using the immune response to push this cancer, much in the way Bob Schreiber at Washington University has described it, in equilibrium, we can actually live with cancer loads. And in fact, there's very good evidence that many of us do, and never have it detected. So if we can because it's under control by the immune response, so if we can minimize disease, that's the best situation to ramp up the immune response and keep it active. And I think we're going to be talking about, and we already have many examples of that in therapy, of people living with their cancer for many years and having a very high quality of life. And that's, I think, what the goals will be really to push forward to achieve.
Dr. Sharon Evans, thank you so much for sharing this exciting research on the People's Pharmacy.
Thank you very much for the opportunity to really talk about this exciting area.
You've been listening to Dr. Sharon Evans, Professor of Oncology in the Department of Immunology at Roswell Park Cancer Institute. She's the former president of the National Society for Thermal Medicine. Her research focuses on the cues that drive immune responses during inflammation or cancer immunotherapy.
After the break, we'll find out how cancer treatment has changed over the last century.
We'll learn about a doctor at the turn of the 20th century who used bacterial toxins on his cancer patients with surprising success.
We'll find out how the immune system cells can recognize cancer cells, and we'll learn about cutting-edge research on modified T cells.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you like this podcast of The People's Pharmacy and want to continue the conversation, you can join us online at facebook.com/People's Pharmacy to share your thoughts or comments.
Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of Utterly Smooth Foot Cream with shea butter, helping dry, cracked feet feel soft and smooth. The number's 800-345-7339, online at uttercream.com.
If you'd like to purchase a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1029. That number again, 800-732-2334. Or you can place your order online at peoplespharmacy.com.
Today we're exploring the latest research on immunotherapy for cancer. How does this new approach actually work?
Dr. Jonathan Cerroti holds the Elizabeth Thomas Endowed Chair for Medicine, Microbiology, and Immunology at the University of North Carolina at Chapel Hill. He's the Associate Director for Translational Sciences in the Lineberger Comprehensive Cancer Center at UNC, and he runs the Leukemia and Bone Marrow Program in the UNC Cancer Hospital.
Dr. David Kroll is a pharmacologist and former cancer investigator whose research focused on the discovery of drugs from natural sources. He's now a freelance science and medicine writer who contributes to Fords.com and other outlets.
Welcome to the People's Pharmacy, Dr. Cerroti and Dr. Kroll.
Thank you. Pleasure to be here.
Let's start with you, Dr. Cerroti, if you don't mind, and just get a quick snapshot of cancer treatment over the last 100 years. Go way back, and it was surgery. I mean, that was really the number one approach. If you couldn't cut it out, you basically were out of luck. And then along came chemotherapy and radiation therapy. And the idea has always been, well, if you could get it early enough, you could maybe cure cancer. But in most cases, you never could get it early enough. And even in some cases where you thought you did, it came back 2, 3, 5, 10, in some cases even 20 years later. So it seems like the basic foundation upon which cancer treatment has been, based for the last 100 years has some serious drawbacks.
So I think that's correct. So clearly, if you were in the 19th century, what you wanted was a surgeon who worked as quickly as humanly possible because there wasn't anesthesia and that was the only treatment available. Towards the end of the 19th century, early 20th century, there was a fellow at, again, what's now Memorial Sloan Kettering Cancer Center, which was the New York Surgical Center, William Coley, who was the first person to actually advocate the use of immune-based therapy for cancer. And so he had a large number of individuals with sarcomas. He treated some...
Describe sarcoma, please.
So sarcoma is a soft tissue cancer that usually involves muscle or bone or cartilage or something similar to that. They're often curable if surgically removed, but once they've disseminated, they're incurable. And he, by serendipity, found that some small percentage of the patients that he treated surgically developed a bad skin infection around the surgical site, and some of those individuals went on to get regression of established metastatic tumors. And so over the next 20 years, he developed what we call Coley's toxin that he injected into patients, and these were live bacterial cultures, mostly streptococcal species that he injected. Unfortunately for Dr. Coley, right around World War I, was the development of nitrogen mustard, which was initially used, unfortunately, on soldiers in Europe, but eventually was shown to have very prominent anti-tumor properties. And that really initiated, along with radiation, the next 60, 70 years, which moved away from Coley's approach, which was immunotherapy, and towards the cytotoxic approaches, which were chemotherapy and radiation therapy. And probably the ultimate feature of that was testicular cancer, which in the 1970s was incurable until individuals realized that if you combined 3 specific chemotherapy drugs, as Lance Armstrong received, you could cure widely metastatic testicular tumors. And that became the paradigm, unfortunately for all of us, for the next 15 or 20 years. But it didn't work in any other tumor other than germ cell tumors. So we've looked long and hard, giving huge doses of chemotherapy with transplants and other approaches to try to cure individuals with radiation or cytotoxic therapy that in most settings in the metastatic situation for solid tumors doesn't work.
Now, as I understand it, Dr. Cerroti, William Coley didn't know exactly how his Coley's toxin worked. He just knew that it did more often than the surgery did. Is that right?
That's correct. So unfortunately for William, science was about 80 years behind him.
He was ahead of his time.
Correct. So he knew that infecting individuals with bacteria worked. He didn't have any understanding of innate immunity. He didn't know what he was doing at a basic level. But he did know that clearly it worked. And he spent the next, 20 years after his initial description trying to characterize that and standardize that a bit more in an area where he didn't have the tools immunologically to understand what he was doing.
But basically, immunotherapy kind of fell by the wayside. So even though he didn't quite know what was going on, And even though he got a pretty substantial response, it's my understanding that some of his sarcoma patients were alive 20, 30, 40 years later, and that it was a better response rate back then than we have today. It just faded from view for, 50, 60, 70, almost 80 years.
Yeah, I would say probably 70 years. There were a few people associated with Coley that tried to continue the work, but yes, once these cytotoxic therapies came along and people thought that that was the avenue for cure, his approach faded away, quite markedly, so that by the 1970s, almost no one was using immune-based approaches for treatment of patients with cancer.
Even today, I would hasten to suggest that most patients treated for cancer in the world are treated first with surgery, if it's appropriate, if it's a solid tumor, second with chemotherapy and or radiation therapy, and the results are still so-so for a lot of cancers.
So especially for metastatic solid tumors. So I think, in fairness, we've done a reasonably good job in identifying cancer earlier, so being able to surgically remove it earlier. And in certain types of cancer, we've been able to make substantial headway, and we've clearly improved outcomes. But once you have a solid tumor that's left that area and metastasized, then the outcomes, unfortunately, for most of those patients are dismal. And while we give radiation and chemotherapy to those individuals, by and large, we're not curing anybody. We're treating but not curing.
What do you think has led to immunotherapy coming back into scientific favor?
So I'd say probably three things. I mean, one was a substantial amount of research in the late 1990s into the 2000s around how immune cells work and what blocks them from working. So there's been, for a long time, up until maybe recently, a huge public-private partnership between those of us who do NIH-sponsored research, who do funded very basic research to understand mechanism, and drug companies who take that research and develop drugs. And in the 1990s, several investigators, Li-Ping Chen at Johns Hopkins and Jim Allison at that time, who was at the University of Pennsylvania, characterized different pathways that were important for blocking T lymphocytes from functioning. They were initially looking at them in viral infections, but subsequently was shown that they were very important for tumor activity as well. And so starting in the 2000s, drug companies started to invest in these pathways, and they developed antibodies against the two most prominent proteins in this area, CTLA4 and PD-1, and a third one against a ligand called PD-L1. And those have been really quite active clinically. That's part of it. The second part is that these have been unbelievably active across multiple types of cancer, which is very different from the paradigm for small molecules where you treat a specific mutation in a specific type of cancer. So we have remarkable activity for patients with metastatic melanoma, lung cancer, bladder cancer, and certain aspects of breast cancer and renal cancer. That's not been seen in the past 10 or 15 years with other therapies.
Dr. David Kroll, I'd like to turn to you for a moment because Dr. Siroti has mentioned this thing called T lymphocytes. For a lot of our listeners, it's like, what exactly is he talking about? And part of your responsibility with Forbes.com is translating complicated medical ideas into language that people can understand. So help us get a sense of, where this immunotherapy process is evolving.
Yeah, actually, so it's interesting that Dr. Siroti mentioned Dr. Allison, formerly at University of Pennsylvania, now at University of California at Berkeley's Cancer Research Institute. And he has a great story. He calls T lymphocytes the soldiers of the immune system. These are the cells that are intended to keep our body safe from invaders. And among those invaders, like viruses, bacteria, parasites, we also should be considering cancer cells, our own cells, that begin growing uncontrolled or don't die when they're supposed to, the way that many normal cells.
Now, these are not invaders. These are more like homegrown terrorists, right?
Well, and I think that's the problem, Terry, that sort of faced chemotherapy in the treatment of cancer throughout history is that, surprisingly enough, cancer cells are remarkably close to our own normal cells. In fact, we normally have cells growing almost as fast as cancer cells in our bone marrow to replace all of our red and white blood cells, as well as in the lining of our gastrointestinal tract. We're constantly growing and turning over cells normally. So as you can tell, some of these particular targets are sometimes side effect targets for conventional, what we call cytotoxic or cell-killing chemotherapy.
Dr. Kroll, if the cancer cells that are growing inside our body are really a form of our own cells, how does the immune system actually recognize them? They look a lot like us, don't they?
They certainly do, and I think that's really been the focus of basic and clinical researchers, is to find out what is specifically different between cancer cells and the corresponding normal cell. And what we've learned, particularly through the work Dr. Siroti referred to, is that cancer cells oftentimes produce proteins on their surface that trick the immune system into ignoring them, even though the protein is still there. Even though the protein is produced on the surface of the cell, it blocks the T cells from actually recognizing it as foreign.
Now, Dr. Siroti, your group at the University of North Carolina is moving to a whole new level of cancer treatment, and you're about to begin clinical trials. This involves removing T cells from individuals with cancer, doing something to them, and we want to know what that doing something is, and then putting them back in the body so that they can go to work against cancer. Give us a sense of what this frontier of cancer research is leading to.
Sure. So T lymphocytes are wonderfully good at finding and killing cancer cells, but have one big problem associated with them, which is the way they find tumor cells is through a receptor that's not a very robust receptor and that's easily manipulated by the cancer cell into not being recognized. So about 25 years ago, an investigator, Zeev Eshar in Israel, decided that what he was going to do is put an antibody portion. So antibodies are things that you make, proteins that bind to other proteins at a much higher affinity than the T cell receptor. He'd put an antibody binding portion into a T cell. And now you have a cell that can kill like a T cell, but bind at the affinity of an antibody. And his initial cells didn't work wonderfully well because he didn't understand some of the aspects of what's necessary for a T cell to grow and kill. But over the next 15 years, the group at Sloan Kettering Cancer Center and then the group at the University of Pennsylvania, so Michelle Sadelaine and Carl June, identified ways to make those T cells grow, expand, and kill. We call these CARs, or chimeric antigen receptor modified T cells. And what that means is we take the binding portion of an antibody and put it into the T cell. And the way we do that most commonly is by infecting the T cell with a virus, much like the virus that you have when you get infected with HIV, except this is not a virus that can be competent to cause any other problems. So it can't replicate anymore.
And
it's an altered HIV-like
doesn't make you
virus.
sick.
Correct. It in and of itself does not make you sick. But using the technology around viral infection that's been understood for the last 20 years, we can put that part of the antibody into the T cell. Now the T cell can be expanded in a laboratory and then given back to an individual with cancer. And so we use your own T cells. We virally infect them with this antibody binding fragment. We expand them, and then we give them a couple weeks back to you.
And then what happens?
And then if you've got acute lymphoblastic leukemia, about 2/3 of the time you go into complete remission. So the disease goes completely away. And about half of the time it stays away. Now the studies haven't gone out multiple years. The average length of time for follow-up is about 9 months. But about 50% of these individuals never have recurrence of their leukemia again, which is unbelievably remarkable. So when you consider that no chemotherapy drug that I'm aware of has that level of activity in the widely refractory setting.
Are you talking about one injection?
I'm talking one injection, yes.
So instead of coming back once a week, twice a week for your chemotherapy, you go in, you get one experience having removed your T lymphocytes, your T cells, getting them infected with the virus, I assume multiplying in a test tube, re-injected once, and half the patients are basically cured.
So far, that's exactly right.
Dr. Cerroti, with the treatment that you're developing at UNC, it's my understanding that you're primarily concerned about metastatic disease. And when these T cells are re-injected into patients, they're not just going after the primary tumor, but they're also going throughout the body to seek out aberrant cells and really knock out the malignancy in all of the places where it may exist and where it may be hiding.
So that's correct, Joe. In most instances, if you have a primary cancer, you can be cured reasonably successfully with surgery and some combination of chemotherapy or radiation therapy. Where we talk about using immunotherapies almost exclusively in the metastatic or advanced local setting where those treatments have not been effective. And the major benefit of immunotherapy, besides the fact that it's relatively safe, is that immune cells have the capacity to migrate throughout the body and to find abnormal cells like they would for an infection and to destroy those abnormal cells. And so that's true for both the antibody therapies, these checkpoint inhibitors, which can induce immune responses in multiple different places, as well as these infused T cells, which can travel to multiple different places to kill tumor.
Well, that certainly sounds exciting. Dr. Jonathan Cerroti, Dr. David Kroll, thank you so much for talking with us on the People's Pharmacy today.
Thank you.
Thank you.
You've been listening to Dr. Jonathan Cerroti, who holds the Elizabeth Thomas Endowed Chair for Medicine, Microbiology, and Immunology at the University of North Carolina at Chapel Hill. He's Associate Director for Translational Sciences in the Lineberger Comprehensive Cancer Center at UNC and runs the Leukemia and Bone Marrow Program in the UNC Cancer Hospital.
Dr. David Kroll is a pharmacologist and former cancer investigator whose research focused on the discovery of drugs from natural sources. He's now a freelance science and medicine writer who contributes to Forbes.com and other outlets.
We spoke earlier with Dr. Sharon Evans, professor of oncology in the Department of Immunology at Roswell Park Cancer Institute.
Lynn Siegel produced today's show. Al Wodarski is the engineer. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
To order a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1029. That number again, 800-732-2334, online at peoplespharmacy.com.
And when you visit our site, you can check out information on prescription drugs, herbal medicines, and home remedies. Share your own experience and your thoughts on today's show. You might want to listen to the extended interview with Drs. Kroll and Cerroti. They discuss the new monoclonal antibody drugs and how they work, as well as cutting-edge research involving a modified polio virus that targets the brain cancer glioblastoma.
At our website, you can also sign up for our free online newsletter or the free podcast of the show. You'll never miss another People's Pharmacy program again, and you can share it with a friend. It's all there at peoplespharmacy.com. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thanks for listening. Please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to the People's Pharmacy.